Hello, everyone, and welcome to another edition of the Hindu Wellness Series. Today's webinar on advanced heart failure treatment is presented by Kaveri Hospital. We have with us two experts who will elaborate on heart failure and the treatment modalities. We have Dr. S. Aravinda Kumar, who is the Chief Consultant, Interventional Cardiologist, Kaveri Hospital, Tiruchi. He has more than 20 years of experience in cardiology and is trained to do all major interventional procedures. He's a pioneer in establishing interventional cardiology program in the Delta districts of Tamil Nadu. He has performed over 5,000 angioplasties in Tiruchi and 2,000 primary angioplasties in Tiruchi. He was the first to do complex PCI, CPO, left main PCI, dual chamber pacemaker, ICD, CRT, and device closures in Tiruchi. We have with us Dr. Kumud Kumar Dittal, the Program Director of the Heart and Lung Transplantation Unit at Kaveri Hospital. He has over 25 years of experience in cardiothoracic surgery and 20 years of experience in heart and lung transplantation and mechanical circulatory support therapy. Dr. Dittal is known the world over as the surgical pioneer of DCD, which is donation after circulatory death heart transplantation, the first of which was performed in 2014 while he was at St. Vincent's Hospital in Sydney, Australia. As a principal surgeon, he led the team right from the initial organ retrieval as well as the DCD transplant procedure. His pioneering effort was initially acknowledged and recognized by thoracic transplant programs in the UK and Europe, with subsequent adoption in the US from 2019. Dr. Dittal is also experienced in DCD lung transplantation and was also instrumental in proving the efficacy of machine perfusion of donor lungs, having been the principal investigator for Australia and member of the International Inspire trial. A medical alumnus of the University of Oxford, he has worked at top hospitals in the UK, Europe, and Australia, and is a recipient of numerous awards and honors. His areas of specialization include heart and lung transplantation, DCT heart transplantation, management of end-stage heart and lung failure, and mechanical circulatory support. Thank you for joining us, doctors. Before I invite Dr. Aravinda Kumar to talk to us, I request our participants to post your questions in the Q&A box. We will take up the questions towards the end of the session. Over to you, sir.
Good morning. Thanks, Serena Josephine, for the kind introduction. I'll be giving a small presentation of what I am going to talk with for the next 10 minutes. From there on, the question and answer session can go on after Dr. Kumud's talk. Right. Share screen. Is my screen visible?
Not at all.
Not yet, sir.
Share.
Yeah.
Right corner. Now is it visible?
Yes, sir. Please go ahead.
Okay, fine. Good morning, all viewers. It's a pleasure and honor to be part of the wellness program conducted by Hindu. So the next few minutes, I'll be talking on heart failure management. With being a cardiologist, I'll be primarily focusing on the basics, make you understand what is heart failure. From there on, we'll move to the advancement, and which will be carried on further by Dr. Kumud. Next. See, this is the heart is all about. On the left side, you got the intact heart. So some insult happens to the heart. It means that once you go to the right side, you will find the heart is enlarging. It becomes more and more enlarged, and it is not effective in capable of pumping blood. which is required for all parts of the body. So this is the heart, which organ which pumps the blood to the all parts of the body, which is not capable. So that's the reason heart failure is going to be a difficult task to treat, because all organ perfusion, all organs working depends on the heart's efficacy. So how that progresses? Does it happen immediately, or it happens over a period of time? Generally, the unfortunate few with a myocarditis and have a fulminant heart failure, it means the heart deteriorates very rapidly and the patient die within a couple of weeks or within days. Most of the time, it gives you adequate time. So the adequate time is the one which is the asymptomatic LV dysfunction that we call. From there on, the body system tries to compensate for a longer period of time, beyond which it becomes decompensated and heart fails and all the symptom happens. So you see the natural history of heart failure progression. If you happen to see, it doesn't happen gradually. There are multiple punctuations of hospitalization and decompensation. So every time the patient decompensates, you have some punctuations of hospitalization. From there on, the deterioration becomes much more rapid, and eventually the patient will lose the life. During some index hospitalization, patient may die also. So this is the reason why we are much worried about the heart failure. This will make you much more clear of what is happening. See here, there is, when the bottom you are seeing 1, 2, 3, 4. From the first two stages, relatively little symptomatic or asymptomatic. The third stage where the symptom starts increasing. Once the heart failure becomes florid, the red line is the one which makes the sale shows about the survival. Survival rapidly decreases and the hospitalization, the morbidity and mortality increases. So it means that once you are not treating the heart failure properly, you are likely to lose the life and rapid deterioration over a period of time. So is all the patients are going to have the heart failure and hospitalization? You can see the graph here. The more the older patients are likely to get hospitalized than the younger patient because of the comorbid condition, because the patient might be having diabetes, hypertension, similarly like all diseases will be there. So this brings in a lot of heart related ailments which make them more prone for heart disease in the elderly. And these people are likely to have a lot of hospitalization, and so much of monetary things are going to be getting involved. So where in India still the insurance has not penetrated much, we will be seeing a lot of spending from the packets. So that is going to be a huge burden for the individual family. So you see the advanced heart failure people, the red track which shows the advanced failure, that is the class 4 we call them. So in the class 4 failure, the mortality is around 70 to 80% within a year. So it means that once the patient is severely sick, they will not cross a year. So we should not be allowing these people to go and die without any treatment. So we have to give the best of care, best of treatment, so that the patient becomes much better. So the rest of the people slowly progresses. It's not that the other people are also going to be living healthily for a long time. So all the people are going to progress. So all our management, advanced heart failure management, is going to revolve around preventing the less symptomatic patient to go and progress into higher symptomatic patients, or treating and saving the patients who are really sick. So what is the magnitude of one of the main etiology of heart failure in India is coronary disease. What is the magnitude of the problem? So in 2015, you can see 6 crores people were there getting affected. And with the growth which with heart failure is happening, it is around 10 to 15 crores now in India. So it means that either they do know about it or they do not know about it. At some point of time, they'll have some eventual fatality. So that's the reason why the biggest problem in India to face now with the advancement of medication, where we make the patient live and we have to make the patient live with comfort also. So that's the reason the magnitude of the problem should be known and we have to address it. So now some certain numbers are there: 0 years, 10 years, 18 to 20 years. So what does it mean? Most of the problem gradually progresses and deteriorates over a period of time. So it gives you adequate time most of the time. Certain diseases are there which doesn't give you, but most of the time it gives you adequate time for you to understand the disease, get it cured. But You have to evaluate, determine the reason for heart failure, and then arrest the progress, and so that the patient lives much longer than this. Because if you imagine a 20-year or 30-year-old going to have a heart failure, you cannot ask them to live only the 20 years. We have to ensure that they are going to live up to 70 or 80 years. This is the major principles of treatment. So the next principle will be the primary thing which is happening is the coronary artery disease. That is, heart is supplied by blood vessel, that is the coronary artery we call it, and there is an electrical system in the heart which we call the conduction system of the heart, and there is a heart muscle. So if anything goes wrong with this, you are likely to have heart failure. So first thing, I'll take the blood vessel. If you happen to see from the birth towards the elderly population, gradually there is deposition of cholesterol, and over a period of time, eventually everybody will have cholesterol deposits in their blood vessel, and which can rupture and can cause a heart attack. So that heart attack can deprive blood supply to the muscles of the heart, thereby heart failure can happen. So that's the reason we need to stop this. So we have to understand, we have to, once this happens, the ultimate best treatment is prevention, primary prevention. So if the patient is a diabetic or hypertension or dyslipidemic or any stresses there, then we have to address it, correct it, educate them, give a health checkup, and make sure that they don't fall into heart failure group category at all. But once it happens, then we have to face it and we have to treat it. So these are the ways of treating it. There are a lot of medications out there. In the bottom, you can see the medications can give you a relative risk reduction of 30%, 40%, 20%. But these are relative. The numbers will be 1 or 2 out of 100. So it means that the medications cannot be the cure for every heart failure. So beyond medication, we have to treat. This is the advanced heart failure treatment. So what else we are going to do? So I told you about the coronary artery disease. So the coronary artery disease is the one which we have to address. So the coronary artery disease, the first and majority of the population falls into this group of people where the obstruction or the occlusion which happens in the coronary artery has to be relieved. So this is what we do by doing a opening of the coronary artery by doing an angioplasty. The next procedure is if there is going to be a multivessel disease, we do a CABG or a bypass graft. We bypass the block and put a new road to the coronary artery, that is the heart blood vessel to the heart, and we can replace a valve. So when the valve is dysfunctional, we can replace a valve. And now that advancement in the field in such a way that you need not even open, we can do a percutaneous valve replacement, which is very much possible in India. So in any part of the world it is possible, and now in India it is frequently done and we are doing it. So percutaneous valve replacement is one another technique with which we can do a better job of saving the patient from morbidity and mortality. Now moving to the next part of the heart, that is the conduction system of the heart. Now I told there is a blood supply to the heart. Another one is electrical activity. We call it as pulse. So normal pulse is 70 to 80 means that the pulse originates in the right upper part of the heart. From there on, it gradually sends signals to all parts of the body, that is in the heart, from where it assists the pumping of the blood. So this is what the heart works in unison. Sometimes with aging or some unknown reason, there is conduction system that the heart's pulse cannot generate properly. That could be the reason for heart failure. We can improve the pulse and get it optimally, have the required pulse by putting in a pacemaker in it. So pacemaker is artificially, we are generating a pulse, simulating the heart, whatever is happening, but it cannot replace the heart's original pulse, but it can simulate and it can give adequate, and we can control the whole scenario. And generally the pacemaker, once it is there, the for some 10 to, so I mean that the next 10 to 11 the patient is going to have a good pulse of their own. But in spite of all your treatment, we have done pacemaker, we have done angioplasty, we have done bypass surgery, we have done valve replacement, everything we have done. But we are going to see here, there is sudden death, heart failure onset. There is in spite of all these things, the patient can die suddenly. This is what will happen. The patient will say, night படுத்து தூங்குனாருங்க, பக்கத்துல தூங்குனாரு, திடீர்னு இளைச்ச மாதிரி இருந்தது, ஃபிட்ஸ் வந்தது, இறந்து போயிட்டாரு. So that the heart can fibrillate, the pulse can spontaneously beat at a very rapid rate of 300, 400 and stop by itself. So this is the reason of sudden cardiac death in heart failure. So that we cannot predict. We can every management, we can make the patient live without any dyspnea, breathlessness, but the pulse, rapid pulse cannot be there. So for that, we have to understand the conduction system which I was telling, we can give one shock therapy to the heart. So once there is an abnormal pulse, generally the abnormal pulse people come to the heart with a rapid heart rate. If they are fortunate, they come into the hospital. Sometimes they die on the way or at home. So if they come here, we try to give a shock. Cinema shock. But similarly, we try to give a shock in the hospital to correct the heart rhythm, to make it normal. So every time they cannot be in the hospital. So for that, what we do is we put in a ICD device. It can shock during the, it will sense the abnormal rhythm and give a shock appropriately, sensing the abnormality and saving the patient. So this is one way of making the patient live. Here you find on the right side, the heart has enlarged and it is not functioning properly. So what we try to do is we are having a device in such a way that we can make the heart work in unison, both sides of the right and left side of the heart, so that the heart regains its lost shape and becomes much more efficient. We call it as CRT. Now I will just condense what I have told you. Treating the patient with the risk factor reduction is the primary treatment. Do not allow them to have a heart failure. That is the primary treatment. So this is what we need to do in your life. So every practitioner or every patient should be encouraged and taught about all the primary prevention and treatment. And if it is not happening and eventually the patient has a heart failure, refer to a variety of reasons. It could be heart attack or it could be valve disease or something else. Then we have to treat with lot of medications. Still it is not possible. Then we have to do intervention like an angioplasty or CABG or valve replacement. Or if the patient has a possibility of sudden cardiac death, we can implant a ICD and heart is not functioning unisonly, then we can implant a cardiac resynchronization therapy. So these are the way we can medically do maximum. But do you think we are successful in making the patient live longer? No. See, in spite of all our treatment, there is still a residual risk is there. See, from this clear picture, in spite of all the best treatment, we can prevent sudden death to some extent, but we cannot prevent the deterioration. The heart failure keeps worsening, the pump failure keeps worsening. So from the 4 or 3, we have to go back to 2 to make the patient live longer. For that, I have our own Dr. Kumud, who is going to talk after me, who can take care of the heart from, make the patient from 4 to 2 or 3 to 2, so that again we can start from fresh and make the patient live longer. Thank you very much for your patient hearing.
Thank you, sir, for elaborating on heart failure and its management. I now invite Dr. Kumud Kumar Dittal to talk to us.
Stop sharing.
I can't seem to share. Somebody else is sharing the screen at the moment. Can you see that?
Not yet, sir.
No, it's not letting me do it. I need.
Stop sharing.
Can you see it now?
No, sir.
It's saying somebody's sharing the screen. Let me try that again. That might work. Is that working?
Yes, sir.
Perfect. Good afternoon. Thank you so much for the opportunity to talk to you a little bit about surgical therapy for heart failure. I'm going to show you very few writing and graphs, maybe 1 or 2 only. So let's start. I could retitle this by saying it's the art of repairing and replacing pipes, portals, and pumps. And simply in the context, though, of heart failure, and which we have just had defined, and where medical therapy, including those interventions Dr. Arvind Kumar has just eloquently explained to you, are no longer making you improve your condition. And they're at their optimal status. So pipes, portals, and pumps is what we do. And that translates to vessels, blood vessels, valves, and ventricles. So just to take you very quickly through this heart on the left-hand side, enlarged on the right shows you these are the arteries of the heart. There's some veins, and we also sometimes have to deal with the larger arteries that exit the heart, whether it be the aorta or the pulmonary artery. And just as a diagrammatic representation to show you the pulmonary valve, the aortic valve, the mitral valves, which are really those portals and gateways to make the blood move from one chamber to another inside the heart in the closed and open positions, as you can see. Now, what about the ventricle? Well, here, this is the left and the right ventricle here, showing you the thickness and these little very fine tissue-like valves that are extremely delicate, and again showing you here in cross-section the right ventricle and then the much thicker left ventricle. And when we talk about heart failure, what are we suggesting is that the heart is just unable to supply sufficient blood, nutrients, hormones to all the organs and the tissues that require it, and at the level they require it, which of course on exertion is far more than when you're at rest. And so all this shows you is what Dr. Arvind Kumar does all the time in terms of angiography, where contrast is given into your blood. And you can see this is the heart filled with blood, the left ventricle. And when it pumps, it empties most of it out. That's a normal emptying of the heart. This one on the right shows you a much larger volume of dye, i.e. more blood inside the left ventricle because it's dilated from heart failure. And when it pumps, it cannot get rid of as much blood. It is failing to pump sufficient amount of blood. Now, what do we do first? Before we go on to transplantation mechanical circulatory support, we offer in dedicated centers, of course, high-risk conventional surgery. And that partly has been explained in terms of bypass surgery, valve repair replacement. We can remodel the left ventricle, and where you sometimes get significant right ventricular failure arising from blockages in the lung arteries, we can do, if appropriate, something called pulmonary endarterectomy. Now here it is. This is a recently done bypass, which just shows you the connections, the new connections to the heart. But sometimes a disease can be so bad that not only is it not amenable to percutaneous therapy, but even conventional surgery where you actually have to pour out this entire disease and then put on your new bypass graft. And of course, there are risks to this, and sometimes you may need to have ECMO support. So this is showing you a series of aortic valves that should look like a Mercedes-Benz sign, and it clearly doesn't, because they have got stenose, they have all this stirring up that can fly off and give you a stroke. And here is one that looks like a single valve, and here is a rare 4-leaflet valve, both of which, however, don't work properly. They leak and cause the heart to enlarge and fail. And we can replace those. We can repair them or replace them with a choice of valves from the pig or made out of a pericardium, the sac outside the heart, from cattle, or when somebody who dies donates their valves and vessels, and we can even use those. And there can be those biological ones or mechanical ones, which tend to last a lot longer, but have the downside of requiring blood thinning for the rest of the life. Now, if you look on the left-hand side, you see this dimpling of the left ventricle, the main pumping chamber of the heart. It means that the muscle wall is almost gone. There's hardly any muscle there at all. It's therefore an inefficient pump. If you open it, it's got this big empty sac which communicates with the actual left ventricle and the blood, which we then have to close off and then repair this to reshape the heart into the shape that it really should be. And again, this can cause problems in perioperative care and needs to be done in a dedicated setting. Here, we've got the dye showing you arteries inside the lung and completely cut off down here and down here, again down here and here on the right again, where we're taking out this blocked material. Once it's out, the function is normalized, the right ventricle returns to normal, and the patient has a normal prognosis. And these are various examples. Imagine this blocking your main pulmonary artery to the left and the right, hardly any blood going through, or all this material that we take out in this procedure called the pulmonary endarterectomy. Now, this is just two examples, a 76-year-old lady and a 31-year-old lady who were hardly able to walk anything and are able to compete, walk, run afterwards. Now, this is the team at Heart-Lung Transplant team at Kaveri Hospital in Chennai. And the reason I'm mentioning is that it is more than just a few individuals. Those are just the clinicians. Imagine the number of allied health and nursing staff that are associated with complex patients in the ICU being looked after and surrounded by all this paraphernalia and machinery. And so we need very highly skilled and dedicated staff. So what do we do for surgery in terms of end-stage heart failure? Clearly, when medical options are no longer possible, and in fact, what happens is all those options are not possible at all, including those high-risk cardiac procedures. And we're left with mechanical circulatory support and transplantation. Mechanical circulatory support has many options in terms of short-term, medium-term, and long-term. The short-term one that you may know is really the small which I mentioned. Now, the other aspect about heart failure is that people are frail. This is a gentleman who's very frail before his transplant. And what that means is that you're not so independent. With an insult, minor illness, you can recover and go back to being non-frail. With an insult where you're in heart failure, you will never get back to normal. And Dr. Arvind Kumar showed you the staging of A, B, and C, and D. The advantage of looking at that in terms of heart failure is that once you enter A, B, B to C, C to D, you can never return whatever happens to you unless you're getting, of course, a transplant or a mechanical support. If you look in terms of NYHA, you can return. But that's just a temporary benefit. It does not give you the prognosis for long term, which is really determined by the staging. And so when you're frail, many patients accept their frailty as a normality, and you must not. It is not the fact that you're getting old. You really have heart failure. You're becoming dependent. You've lost your quality of life, and you need to seek appropriate, advanced, multidisciplinary specialist heart failure centers that are doing this day out. And so here's ECMO. This is big pipes going in and out. It can go from a vein to a vein again to support the lungs, or vein to an artery to support the circulation in terms of heart and lungs. And there's also a single cannula that can be placed in the neck, which can do both the artery and the vein. But of course, this is all about the timeliness of the referral. The longer you leave it, the worse the outcomes and the more invasive the procedure is likely to be. Now, these are a series of heart pumps that we can utilize. They're fairly expensive, but they work exceedingly well, or total artificial hearts. Heart pumps here, some of which are in the market and others about to start this year. And this is how we put in pumps. This is a left ventricular assist device that's sewn in. You can see that metal on the right, this stainless steel cage, which houses a pump sucking blood out of the ventricle and pumping it via this graft onto the aorta. And here it is. And this patient actually has two pumps on the right and the left. And this is how it would look on your X-ray. So patient has got failure of both left and right ventricle. These are used for bridge to transplantation. Sometimes now used also for destination therapy, i.e. the VAD is left in, the pump is left in for lifelong because the patients are usually not candidates for transplantation. This is a total artificial heart where you remove the entire bulk of the heart, all the ventricles, and plumb in two of these devices, which work as the new heart pumping chambers. And this is what it would look like. We're just showing you the four valves, and you can hardly see the plastic. But the important thing is the X-ray on the left shows a ginormous heart that's more than half the width of the chest to one that returns to normal size. And here, a single left ventricular support, biventricular support left and right, and a total artificial heart support. And so heart transplantation used to be much more simpler. We were replacing, for the first time, no previous operations, a damaged heart with a new one. And same thing, a damaged heart with a new one. Now our lives become more complicated because we're keeping patients, at least abroad and less in India, but it's increasing, having to support patients with these artificial pumps, which complicates then the surgery at the time of the transplant, but it keeps the patients alive to very good quality of life if done in a timely fashion. Here you see there's the electrical cable, and here is the graft that would go on to pump the blood from the ventricle into the aorta. And this is the time of transplant, and these are the donor hearts. So what are the results? Only 3 graphs here to show you is that the outcomes of heart transplantation are not bad at all. So the most risk is in the first year. So we lose roughly, this is the international registry, where you're losing about maybe 14% of patients in the first year. But if you look at 10 years, then patients are still alive at over 60-odd%, which is good. Now, if you survive the first year, then your survival beyond that is up by another 10%. So the results are extremely good, but of course you have to stay on immunosuppression therapy, but you have a normal quality of life. And if you come in too late, or you've been supported by ECMO, for example, bridged to a transplant, your outcome is far worse than if you'd come in without. But even with an LVAD, those results are getting slowly better and better because the technology is improving. But the first-time heart transplant, for those that need it and are suitable, is always the best way forward. Now, the problem we have is a shortage of donors, and what do? Here we've got enormous toll deaths and enormous increasing burden of heart disease. The two is very hard to reconcile. We still do. This is how we transfer organs, specially preserved inside and kept inside an icebox in a cooler, picnic cooler, and transferred from the donor hospital to the recipient hospital. And this is way back when I was in my team with the Professor Peter McDonald in Sydney. This is one of our PhD students, Roger Heyer, who was experimenting on pig hearts at the time, which we then developed and took on to doing some very interesting work, which I'll describe. There are lots of new machines that can help transport the heart in a better fashion for a lot longer than 4 hours, perfused cold. This is the device that can bring the heart back beating, which I've been using for now ever since 2006, and which is the technology that allowed me to do the first at St. Vincent's in Sydney with the entire team to do the world's first DCD heart transplant. This is the donor heart then, which then improves on the machine, as you can see. And then finally, after transplantation, she's off every other support there at that stage, and the heart's beating. And of course, that patient I showed you earlier in frailty, 2 years after transplant, looks like that. And this is the lady who had the first DCD transplant. I should add that this is DCD transplant in the context of hearts traveling a distance with it beating en route. She is now over 7 years post-transplant, doing very well. This is the transformation you can get in people from their frailty to post-transplant. And these are other patients who have enjoyed their children's graduations and enjoyed their children growing up and family life, and returning back to work, paying their taxes, contributing to society because they've had the benefit of transplantation. Thank you very much for listening, and I'll be happy to answer any questions. And of course, sorry, one last thing I meant to mention in the context of the recent pig-to-man transplant. Of course, one of the earliest one was done in India itself. Many of you may know that. The patient appears to be doing well still in the States, just over 3 weeks from the transplant. But eventually, yes, we may well be getting more and more organs out of pigs, but I don't think it's going to make a huge difference to our practice in the forthcoming few more years. Thank you for your attention.
Thank you, sir. We will now move on to the question and answer session. Dr. Arvind Kumar,
Yes.
among patients whom you see, what are the common causes and symptoms and signs of heart failure, sir?
Nice question. It's for the common public, so I have to be a bit elaborate, but at the same time, very short. So the common causes, as I told you earlier in the presentation, generally heart means you've got a blood supply, and you've got a electrical activity, and you've got a muscle, and you've got a valve. That's all. நம்ம தமிழ்ல சொல்லணும்னா 4 அறை இருக்கு, 4 valve இருக்கு, 2 coronary artery இருக்கு, ஒரு current path. That's all. It makes very simple, and only 4 medications also as simple as that. So out of the 4 muscle, it's the one which pumps blood to the heart. So when the muscle is per se damaged, you can have some damage, or the heart blood supply is decreased, then you can have heart failure or current system. The common thing in India as far as concern is whenever you grow more than 40 or 50 years, it is all about coronary artery disease and heart attack. That is a common thing which come. In the younger age, 10 years, 15 years, 20 years, it is still the rheumatic heart disease, which is caused by a bacteria because of the lower socioeconomic status. It gets transmitted one person to another. So that bacteria can infect the throat and come to the valve, and it can cause valve damage. It can cause shrinkage of the valve and narrow it, or it can leak. So that way the valve can get damaged. And unfortunate few people can be there with per se muscle disease problem, like a dilated, we call it as dilated cardiomyopathy. So the primary problem is predominantly the coronary artery disease, and the younger age it is valvular heart disease. And then all prevalent, all ages, there are a group of people who have dilated cardiomyopathy or hypertrophic cardiomyopathy, which is the disease. This is the prevalence wise and the incidence wise. And symptom wise, predominantly we call everything as heart failure. It's pertaining to the left heart because the left heart is the one which pumps blood to every part of the body. To define it, there is the ability of the heart to pump blood necessary to supply all parts of the body. That's the, by definition what we need to heart need to do. If it's not able to do means obviously when all organs are not perfused, means the patient feels fatigued, tired. When the heart is not able to pump blood, it accumulates in the lungs. So what happens? Lung is to give oxygen. Oxygen cannot happen. So then patient becomes dyspneic. Then they become worse and they cannot lie in the night and they keep coughing at night. We call it as orthopnea or PND. So there is one another symptom which is there. So the heart is not able to pump blood. So it works harder. So it means that it has to work much more harder. So if the heart rate becomes from 60 to 70, it becomes 100, 110, 120. So they feel it as palpitation. So predominantly dyspnea, palpitation, fatigue. These are the common symptoms that is there. Then they will be having another few other symptoms like when the heart is not able to pump blood to the kidney will retain a lot of fluid inside. That will be manifested as the pedal edema in the legs, and there will be abdominal edema, ascites we call. So these are the common symptoms that the patient comes to you.
Okay. Do you see a rise in the number of patients with heart failure, sir?
Definitely. There is definitely the see, because the awareness is there. Health checkups are happening. Lot of people, we call India as the capital of diabetes and heart attack. So in the world, not in, so in the world, we are having the leading cause for diabetes and heart attack. So it means that the patient has diabetes and they go in for a heart attack. From heart attack, not every patient live with the same life after the heart attack. Once there is a major vessel is there, the heart from the efficiency of 60 to 70%, suddenly you find the efficiency coming down to 30 to 40% or less than 30% also. So these are the people who live with some morbidity. They cannot perform the work. So why the heart failure incidence is increasing? Because we make them live. The treatment modality wise, we have improved a lot. The patient is aware. They come to the hospital. They survive the initial heart attack or survive the initial failure, whatever may be the reason. So we make them live longer. So what happened over a period of time, the number of heart attack people are increasing in number. That is the reason why we are going to have around 10 crore people or somewhere around 10 to 12 crore people living in India out of 130, 140 with a heart attack, whether some out of which quite a few people will not even know what is there because it is an asymptomatic silent case. The morbid manifesting case are very minimum. So that point, those people are the one who comes to the treatment. But health checkups and all the checkups and awareness and the family physician role, everything will bring in more number of patients and we can prevent a heart failure getting worsened or complicated.
Okay, sir. Thank you. Dr. Dittal, can you tell us what are the indications for a heart transplant, sir?
Yes, so indications of heart transplant is essentially when you're in heart failure and you've run out of medical options, but the patient is still a candidate who can benefit from a heart transplantation so that there aren't, for example, other organs involved. So there's no permanent damage to the kidneys, the liver, or the brain. You don't have cancer, and so on. So if you really have a heart problem that cannot otherwise be managed medically or by the percutaneous interventions that have been described, then you should be considered early to be reviewed and worked up to see if you are a heart transplant candidate. And then if you are, to be listed as soon as possible, because one of the problems we have in India because of the shortage of donor organs is that you need to be placed on the list earlier than elsewhere because you don't want to be, well, we don't want to be losing that patient on the wait list. Because then the only way to salvage that patient, if they come in decompensated acutely, is either to put in a VAD or pray that while stabilizing that patient, a heart becomes available. And often in that decompensated phase, those patients usually have kidney damage or the organs are not working well, and therefore they're not candidates for heart transplantation. So the whole thing is about very early referral to a specialist center to determine whether or not you are. And if you are, you will continue to have a very good quality of life and a shorter stay in hospital. Although, of course, you have to stay on a lot of medication.
How have heart transplants evolved in this part of the country, sir?
Listen, heart transplant, in fact, if you look back historically, I think the world's fourth heart transplant was actually done in India. But then, of course, everybody was trying to do it, and not majority of them were not into the science, and therefore patients were dying of rejection because we didn't have good immunosuppression therapies, and heart transplantation, in fact, died pretty much, except in some centers around the world, very few, because the results were so appalling. With the ability to preserve hearts and to carry them at a distance, as I showed you in those ice coolers, and the improvement in immunosuppression drugs that we can now utilize, heart transplantation has become a very advanced and well-known therapy. It's the gold standard therapy. Now in India, it is on the rise for sure. There are probably about 100 approved centers, but only a handful are actually doing any significant numbers. And the problem is that how do we get them to do more? We can't get them doing more if there are not enough donors available. The other problem when we have many centers is that the same centers that are doing very few heart transplants will necessarily have to cherry pick the cases. They'll have to choose the best donor to go into the best recipient for fear of doing a more complex procedure and the patient not surviving. However, the downside of, although that one patient may do well, you are disadvantaging so many more patients who would have done perfectly well in a more experienced center because they can carry on because of the expertise available amongst a whole host of clinicians to carry the more complex, i.e. a poorer donor with a more complex recipient safely through that transplant procedure. So that the success of one and the death of many others will not be being worked up translates into the success for many post-transplantation. But it's rising, and we're going to, the other problem we're going to have is that nobody is reporting their data officially in any registry. And India ought to have a national registry for all organ transplantation, so everybody, you, the public, the patients, the clinicians, can see exactly what's going on, the data that can be audited, and data which allows the same clinicians to start publishing the data so that India can be part of evolving the discipline of heart transplantation, because the sheer numbers required in India would mean that we would be doing the highest volume anywhere in the world and to be leading the show rather than following other countries because we are too scared or unable to actually submit our data to registries.
Thank you, sir. We have a question from a participant. What's the role of cardiac rehabilitation in heart failure?
Okay.
Dr. Arvind Kumar? Yeah, please go ahead, sir. Please go ahead.
Arvind Kumar, please go ahead. I'm happy to answer it. Listen, so it is crucial. So one of the things when you come up for a heart review at a specialist heart failure clinic is that of rehabilitation. So if you have not got sufficient muscle mass, you have got cachexia, you have lost a lot of weight because of heart failure, your perioperative course, should you get the transplant, is much worse, which translates sadly, of course, into increased morbidity and huge increase in the cost because you're going to have to spend longer in ICU and in hospital. So the fitter we can get you means that we can almost hold you for longer on the wait list. We might even be able to avoid putting you on the list for another 3 months because we can get you to be doing much more active and get your muscle tone up. So it has an incredibly valuable purpose, cardiopulmonary rehabilitation, for both heart and lung failure patients who need advanced care for their end-stage disease. And we do the same thing after they've had the heart transplant or have been implanted with the mechanical circuitry support to again get them back as far as possible to their quality of life, and not one that they had sadly just got used to and accepted as being the norm. which in India, many people in their 60s and above put it down to their age, and it isn't. It's the fact that they have lung failure, and that needs to be addressed.
Our next question from a participant is, what is the success rate when Impella is required to be used?
Okay,
Dr.
so Impella is a short-term mechanical circulatory support system that can, in its simplest form, there's several types, can be put percutaneously, as Dr. Arvind Kumar could do. For example, if he has a very complex and high-risk intervention to do in terms of doing this angioplasty, then instead of having the surgeons in standby for a potential ECMO, he can utilize the Impella that can just go in via the blood vessels, and it offloads the left ventricle safely and allows the procedure to take place. The other, and that's been used at Kaveri, and in fact, Dr. Anantaraman has also been using that as part of the group amongst the Kaveri cardiologists. Now, the other thing is that it can be used in acute decompensation, somebody who's had a heart attack, who is undergoing a heart attack, and the left ventricle is not pumping or the right is not working well. And you can, particularly for the left ventricle, use this device to buy time. Now, when the patient needs much more support, you can still use an Impella in the 5 liter per minute instead of the 2 liter per minute, but that needs a surgical graft to be placed on the artery in the chest, under your collarbone, and the patient can then be safely managed. But of course, this is a bridge. This is a bridge to decision-making. It's a bridge to recovery, potentially and hopefully, or it can be a bridge to and palliating because the patient is no longer a candidate for subsequent therapy that might be required, or most typically a bridge to transplantation. But the Impella, when used in its minimalist form, is a very good device, though expensive, for buying time and making the same high-risk surgery far less riskier.
Okay, sir. Dr. Arvind Kumar, there's a question on mild thickening of the valve. What does it mean in the long run?
See, thickening of the valves is something which it's like a wear and tear in the valve. So with the aging, generally, or some due to some disease that we call it as well, the common disease which we come across in the younger populations, the rheumatic heart disease. So the inflammation, that is any bacteria or anything related to the antibody reaction to the bacteria, it can adhere to the vessel valve. Once it adheres, there is a foreign one. So our body system tends to fight with it. That's the reason for thickening of the valve which happens. This is one part of rheumatic heart disease which is there. The thickening is with the wear and tear, with the usage of muscle, with the usage, it is going to increase with time. It can dramatically shrink, or it cannot close properly. It can leak or also cause stenosis. This is what happens in the younger age. Whereas in the young elderly population, as the patient lives longer, we have the aortic valve, that is the valve which pumps between the left ventricle into the aorta, which pumps the blood to all parts of the body. That is the valve which is overworking. It is exposed to high pressure of the blood pressure which is there. So the ventricle has to pump blood against this pressure. So because of this, the valve becomes much more harder work, that the wear and tear is much higher. It becomes thickened. We call it as aortic sclerosis or thickened aortic valve. So sometimes this thickened aortic valve can progress into severe aortic stenosis with time, where in the elderly population in the 70s and 80s, we are seeing severe aortic stenosis, that is the valve is not opening properly. This is a potentially the surgical candidate or a percutaneous valve replacement candidate. Not every people, that I do not want to frighten you with this condition. Not every people happen. It happens in probably 5 in a lakh or something like that. It potentially worsens. It's relatively less, but it is going to be much more common because as the patient is going to live longer, as the longevity in India increases, we are going to see more and more people in this.
Okay, sir. So there's a question on why do youngsters who are also health conscious die of sudden heart failure?
See, the heart failure could be due to a variety of reasons, as I mentioned earlier. If there is the immaterial, whether it's young or old, if it is destined to have, it is going to be there. So there are some genetic disease which is not there, which is not underlying present there in the body, which is not at all seen or it is not manifested until he was diagnosed at that point of time. You can see a kind of genetic disease like a hypertrophic cardiomyopathy. The patient lives, in fact, you can see last European football competition also, you find a Danish midfielder where defender fell suddenly because of a sudden cardiac death. So you find that the patient has a possible hypertrophic cardiomyopathy, the thickness of the heart muscle which is there, which was not at all picked up throughout his life, and he was a good athlete. So likewise, there are a lot of people who live with this disease for a long, long time, which is not there. So these are the reason why there is a youngster having it. And the youngster now in the IT field, which is flourishing, where people are working for Western countries, not India. So they have to work at night. So their circadian rhythm is totally discarded. They cannot, they have to sleep between 11 and 6 mean they do not do it. So they are, wake up at around 3 or 4 in the morning, and that is not the good way for heart, because the muscle, heart, our brain, everything has to sleep. So it's not sleeping. So that is the reason why there is a thickness of muscle is happening. Lot of younger people are going to have heart failure, myocardial infarction, stroke, kidney failure. Everything will be there because you are having a deranged life, stressful life. You are not sleeping properly, and you are sitting and doing the work, and becoming obese and contracting a lot of obesity-related risk factor like diabetes, hypertension, dyslipidemia. On top of it, you are stressed. There is an intense competition is there in the field, whatever maybe the field you are taking. So it all makes you a potential candidate for having young people having a lot of disease. And that's the reason failure is also on the higher side. And incidence of all these are increasing on the higher side.
Dr. Dittal, there is a question on life of the graft. Is it only
Yes.
20 years or more, sir?
No, so I told you the results earlier on. So at 10 years, you're expecting over 65 patients, percent to be alive. If you survive the first year, it's even better. At 20 years, there are, of course, quite a few survivors. But in that interim time, patients are slowly going to die for multiple reasons. A reason of chronic rejection, which affects all organs that we transplant. The potential of having cancer, because one of the reasons that you need to have immunosuppression is so that the heart doesn't reject that organ. But the downside of having immunosuppression is that you lower your own defenses against infection and cancers. So the longer the time from your transplant, the longer is the risk of getting some forms of cancer. Typically, most of these are very simply dealt with as skin lesions. Of course, occasionally we will see somebody down the line who may have something more serious, for whom we may have difficulty managing or not be able to do something. But there are patients, certainly increasing number of patients, who are alive more than 20 years after their heart transplant.
Okay, sir. There is a specific case. This participant says, I had 3 heart attacks in 2004 at the age of 44, had 3 stents, and then at the age of 58, and then again at the age of 60. The family has a family history of high cholesterol. He's now 62 years and he takes medication regularly. What else can be done to prevent further damage? Dr. Arvind Kumar, can you take the question, sir?
Please. See, this is what the people, this is the history with which the people are going to come to you in future. Because more and more people live. This is a standing example of how the medical management is advanced at this point of time. See, where we lost a lot of people during a first heart attack, now he has survived 3. So it means that the medical management is at its advanced stage, and people are fantastically following and they're living longer. That is kudos to the medical community as well as the patient who is following. But are they going to live forever with this? No. See, it is a atherosclerosis is a progressive disease. That is, accumulation of cholesterol in the vessel wall is a progressive disease. It happens every day, every night. So it is we are going to stop, or we are going to regression is less possible. We can stop or we can live with this. These are the 2 things we can do it. So what we need to do is all 3: diet, which is mandatory. We have to understand we are in a South India where we consume a lot of rice, which translates into a lot of triglycerides, and that is one of the things which carries a lot of risk. That triglycerides in turn causes less HDL cholesterol, which is a good cholesterol. This is the reason why we are having a lot of heart attack in India. So we have to ensure that we have a less carbohydrate. It's not a zero carbohydrate. Paleo diet it is a less carbohydrate. What is prescribed? 50% carb. So if there is, where a patient is able to maintain that less carbohydrate, 50% carbohydrate diet with adequate protein and fat, they live longer. And mandatorily, they have to walk for 3 kilometers at least a day. On top of it, medication. Then we have to pray to God. That's the only thing. So we have to keep doing all these things, and regularly, if you are doing it, then it's going to be a easy job of managing. It's going to happen. Recurrence is going to happen, but only thing we have to sincerely do, take the effort to take it.
Dr. Dittal, I
Yes.
want to ask you, like, has the COVID pandemic impacted the heart transplantation program as such, and has the waiting time become longer for patients?
Yes. So two things. One is it's affected the whole spectrum of cardiac and cardiothoracic surgery, because a lot of the ICUs were taken up by the more needy COVID patients, and of course people didn't also want to be coming in and having the surgeries done. So it has impacted negatively, but we're coming out of the woods, and then now the cases are increasing again. In terms of heart transplantation, if you look at the centers that we know the numbers from, there also case numbers went down significantly. And I think they're now back on the rise. This was just inevitable with the extent of the pandemic. And of course, it meant that patients were waiting. And I have no doubt that some may have also succumbed to end-stage heart failure, may not have then survived on the wait list to wait sufficiently long enough for a suitable donor. The other thing just to remember about that wait time that you just mentioned is that trying to match heart and lungs is very different from kidneys and livers. We can't use the heart and lung from one donor, even if the blood group and tissues match, just from one to another because we need, for example, I can't put the engine of a small Maruti car into a Fortuner. So it's about sizing the power of the organ. So everything may match, but if the heart is not big enough, powerful enough, I can't transplant it. Same with the lung. It's about the size of the cage, in addition to the disease, which affects what you can take from the donor. And even donors who seemingly might be very good can sometimes not be suitable for that recipient. So we have much complex decision making, and that's why not only do we need more organ donors, but we also need to be referred the patients in a timely manner so we don't lose them on the wait list.
And Dr. Arvind Kumar, you already mentioned about seeing younger people with heart failure. So, do you recommend regular cardiac checkups for people?
Yes, so this is a fantastic question. See, first thing, I'll divide it into two groups of people. One who doesn't have any disease, but the subgroup among is who is not aware of the disease what they are having. So two group in the subgroup. So the people who are not aware or who are likely to have the heart disease has to undergo regular health checkups. At what age we need to do it? So in India, being a capital of diabetes and myocardial infarction, heart attack, we are I'm also seeing younger people. We have to start screening the people from 30 years onwards. That's one thing which we have to understand. And if they are comfortable and our tests are out, results are outcome are better, they can do it once in 3 or 4 years once. And if there is a positive family history, by that I mean none of the parents are having a heart attack in the younger age, 50 or 40, 50. Then they have to have every year health checkups so that they do not have the disease, or even if they are going to have, it is in the nascent stage and we are going to treat the patient in a much better way. That is one group of people which is we have to screen. The other group of people having had a heart attack or any sort of a heart failure, that patient has to undergo completely, they have to be with one cardiologist who has to take. And that cardiac rehabilitation is the question already was discussed. So the cardiac rehabilitation is the one which we have to take care and we have to follow. That requires a complete health checkup, which gives a good idea of what is there. So this health checkup should encompass the device, advanced technology which we are having, because the application can track your heart rate, track your abnormal rhythm, track your saturation oxygen level in the body. So everything can be tracked by the application you have and get connected to the doctor and the system with which you are working with. One thing. Second thing, your daily intake of water, daily nutritional intake, diet therapy, exercise therapy, everything can be monitored and it has to be prescribed. So that requires a periodic health checkup and assessment of the patient every year, year on year, so that the patient's overall health, it is that we have to ensure the patient goes to the office or makes a yearning after all his illness. So we have to ensure that the technology is also incorporated in the management of the subsequent management of the heart failure. This is the two way I will divide, and we are going to approach our patients in this way.
Dr. Dittal, can we have your closing remarks, please?
Sure. I think the main message that I'd like to give, given so many people are listening, well, firstly, I'd like to thank the Hindu and yourself for hosting this session. To those out there, I'm just going through the questions. It's obvious that we have a problem where medical profession needs to be explaining things a little better to their patients, because a lot of the questions here are from patients who have got obvious medical therapies ongoing, they're ill, and they still have some questions that really should have been answered already for them. The important thing that I can't stress enough, and that's the main message, is that if you have any signs of heart failure, you're known to have heart disease, if your quality of life is decreasing, and an echocardiogram shows the ejection fraction or your pump power is low, or moderate or decreasing over time, you need to be seen by somebody who is very knowledgeable with heart failure management. And that typically happens in a dedicated center, but there are some cardiologists who obviously keep this as a niche practice. And so that is the most crucial thing. And they will do all the right investigations. And if appropriate, then reach out to us in the sort of transplant mechanical support so we can have co-sharing, co-management to reassure the patient that the time is not ready for them to have anything extra, rather than saying to them, I'm sorry, you've arrived too late, you risked it too high, or you're not a candidate at all.
Thank you, sir. Dr. Arvind Kumar, your closing remarks, please.
People has to live healthily. That is the most important part. My carry home message from my side is very simple. Prevention is better than cure. Say we all have the skills to do. We have advanced and we have been technically good enough to do all sort of procedure under the world, and what is happening in any part of the world we are doing. But our skill is not going to be useful to make the patient live longer. It is only prevention. So live a healthy life, sleep well for 7 hours in the night, control your diabetes. If there's something destination, diabetes, hypertension, dyslipidemia, if there is going to be hereditary, it is going to come to you. But controlling is in our hands. Control your diet, walk at least 3 kilometers, sleep well, have a relaxed life. Do not take too much of stress, but at the same time, you have to be very conscious about the way we are working and take care of the family. Thank you very much for the opportunity.
Thank you, sir. So that brings us to the end of the session. I thank Dr. Arvind Kumar and Dr. Dittal for taking part in the session and providing our insights on heart failure and its treatment. I thank all the participants, and I hope the session was beneficial for them. Thank you so much. Thank you, sir.
Thank you very much.
Thank you. Thank you.
Thank you so much, doctors.